Assalamu alaikum everyone. Next topic of discussion is lymphoma. Lymphoma are the malignancy that arise from lymphocytes, and they can be either classified as Hodgkin, which are characterized by red Sternberg cell, or non-Hodgkins. Non-Hodgkin are further classified according to cell type, which can be B cell, T cell, NK cells, on the basis of location, nodal or extranodal, and on the basis of tumor grade. Low grade originate from the mature cells. The most common low-grade B-cell lymphoma is follicular lymphoma, while the most common low-grade T-cell lymphoma are the uh, mycosis fungoides. Hodgkin lymphoma is a malignant lymphoma that arises from the B cells. The incidence followed by modal age distribution, peak incidence in the third and 6 to 8 decades of life. The major classify into two types: classical and nodular lymphocyte predominant. 95% of the individuals with Hodgkin have classical Hodgkin lymphoma, which include four histological subtypes. Nodular sclerosing is the most common mixed cellularity lymphocyte rich and lymphocyte depleted. The remaining 5% with Hodgkin have nodular lymphocyte predominant Hodgkin lymphoma. So as we have discussed that the lymphoma originate in the lymphatic tissues and arise from the mature cells. Some also arise from the premature like pre-B cells known as lymphoblastic lymphoma. CLL, which arises from mature B cell and memory B cell, chronic lymphocytic leukemia. It's considered leukemia, but it arises not in the marrow, but it arises in the lymphatic tissues. But later on, the cells increase in the blood. That's why it's called leukemia. The other that arise from the activated B cell are follicular lymphoma, diffuse large B cell lymphoma, and Burkitt lymphoma. Plasma cells malignancy can lead to multiple myeloma. Hodgkin lymphoma is more common in male and especially in kids cases, while in nodular sclerosis case, its prevalence is equal in male and female. Young adult nodular sclerosing is common, while in elderly mixed cellularity is common. Its first peak occurs between 25 to 30 years of age, while second peak occurs 50 to 70 years of age, so it has bimodal distribution. Etiology so strong association with Epstein-Barr virus, immunodeficiency, and also autoimmune diseases like rheumatoid sarcoid. Clinical feature: we will have painless lymphadenopathy first develop in a single group of lymph node, typically cervical, supraclavicular, and or mediastinal. Mediastinal may manifest with chest pain, dry cough, and shortness of breath. It continuously spreads to the lymphatic system, for example, from the cervical node spread to supraclavicular, then to the axillary, and then to the inguinal node. Then we will have splenomegaly or hepatomegaly and B symptom: night sweat, weight loss greater than 10% in the past 6 months, and fever greater than 38 degrees C. In the cases of confirmed Hodgkin lymphoma, the presence of a single B symptom is sufficient for a positive diagnosis of B symptoms. Epstein fever, so this is an intermittent fever. High temperature for 1 to 2 weeks, followed by a febrile period for 1 to 2 weeks. Relatively rare but very high specific finding for the Hodgkin lymphoma. Then we have alcohol-induced pain, so pain involved in lymph node after ingestion of alcohol, relatively rare but highly specific. And there will be pruritus, focal or generalized. Diagnosis of biopsy is required to confirm the diagnosis in patient with unexplained lymphadenopathy with or without B symptom. Once the diagnosis is confirmed, so further study including PET-CT are required for the staging. Initial study shows CBC with differential, there will be elevated or decreased WBC count, there will be anemia, most commonly anemia of chronic disease, but may be a Coombs positive hemolytic anemia or secondary to bone marrow infiltration. Anemia is a poor prognostic factor. There will be eosinophilia, thrombocytosis, or thrombocytopenia. Thrombocytopenia may be the result of bone marrow infiltration or hypersplenism. Comprehensive metabolic panel, you will have transaminases and or hyperbilirubinemia, elevated alk-Phos, hypoalbuminemia due to involvement of the liver. And then you can also have hypercalcemia. It's uncommon, but it's due to paraneoplastic production of 125 dihydroxyvitamin D. ESR will be elevated, and LDH is elevated in 35% of patient diagnosis and may be indicator of tumor burden. Imaging can also be used, for example, ultrasound, CT, and chest X-ray to evaluate for the lymphadenopathy, hepatosplenomegaly, generalized lymphadenopathy, for mediastinal lymphadenopathy. Confirmation. So for the confirmation, gold standard test is excisional biopsy of the lymph node or extranodal site. Finding Hodgkin cell and Reed-Sternberg cell are popcorn cells. Differentials, so differential non-Hodgkin lymphoma, Hodgkin lymphoma, other like CML, ALL, TB, HIV. So these all are the differential diagnosis of the B symptoms. Now this is the table to differentiate between Hodgkin and non-Hodgkin lymphoma. So on the basis of age, Hodgkin has bimodal distribution like later adolescence and older adulthood, while non-Hodgkin are usually common in patients with age greater than 50 years. Etiology, so here is EBV infection and immunosuppression are usually the cause, while in non-Hodgkin we have chromosomal translocation commonly 1418, autoimmune disease like Hashimoto thyroiditis, rheumatic disease, and infection like HIV, EBV, and HTLV1. Lymph nodes, so in Hodgkin lymphoma we have lymph node involvement usually above the diaphragm, and there is continuous involvement of the lymph node, and the external nodal involvement is rare. Here we have multiple lymph node groups, and these are non-continuous spread, and extranodal involvement is common. On histology, we will have Reed-Sternberg cell and Hodgkin lymphoma, while there will be neoplastic cells of B cell lineage in non-Hodgkin. 5-year survival rates, it's higher for the Hodgkin, 80 to 90, while it's 70 for the non-Hodgkin lymphoma. On pathology, we will have Reed-Sternberg cells that are pathognomic for the Hodgkin lymphoma originate from the B cell. These are the large cells with binuclear or bilobed nuclei with dark center and pale halos, which result in the oval eye appearance on histopathologic examination. These are CD15, CD30 positive. What are the Hodgkin cells? These are mononuclear malignant B lymphocytes. Inflammatory background contain the following cell type and varying number: lymphocyte, neutrophil, eosinophil, macrophages, plasma cell, and fibroblast, and there will be granuloma formations. So these are the Eastern cell with oval eye appearance. These are binuclear cells, and these are the popcorn cells which are present in nodular lymphocyte predominant Hodgkin lymphoma. As the Reed-Sternberg cells are binucleates, two nuclei with CD15, CD30 positivity. To recall or to remember, we have 2 multiplied by 15 equal to 30. So 2, we have 2 nuclei, and we have 15 and 30 CD marker positive in Hodgkin lymphoma. So histological classification of Hodgkin lymphoma, we have classical Hodgkin lymphoma which comprise about 95% of the Hodgkin lymphoma. In subtype, we have nodular sclerosing, we have mixed cellularity, lymphocyte rich and lymphocyte depleted types. And then another type we have lymphocyte predominant Hodgkin lymphoma, which is 5% of the total. So in classical Hodgkin lymphoma, further we have nodular sclerosing, which is the most common subtype, about more than 60%, and it's localized in mediastinal and cervical area. Its prognosis is good, and on the pathology we have Reed-Sternberg cell with leukemia separated by collagenous tissue with sclerosing appearance, hence the name nodular sclerosing. So here is sclerosis due to collagenous tissue, and these are the lymphocyte rich. Then you have mixed cellularity, so it's commonly found in immunocompromised patient like HIV positive, and it is mostly localized in abdominal and splenic area. Its prognosis is also good. Nodules with numerous Reed-Sternberg cells and increased number of histiocytes, eosinophils, and plasma cells. So due to different cell lines, it's called mixed cellularity. Lymphocyte rich, it's mostly cervical and axillary location, and its prognosis is very good. And there are Reed-Sternberg cell and reactive lymphocytosis that cause distortion of the lymph node architecture. We have lymphocyte depleted. It's very rare and commonly found in the immunocompromised patient, and it's mostly located below the diaphragm. Its prognosis is poor. There are numerous Reed-Sternberg cell and decreased number of lymphocytes. Then we have second type lymphocyte predominant Hodgkin lymphoma. So it's nodular lymphocyte predominant Hodgkin lymphoma, which is rare and mostly neck, axillary, and inguinal region. Its prognosis is very good, and the presence of popcorn cells, a variant of Reed-Sternberg cell characterized by polylobulated nuclei that resemble popcorn. Lymphocyte predominant cell express CD20, CD79A, and CD45, and the tumor cells are negative for CD15 and CD30. Staging of Hodgkin lymphoma. So Lugano classification of lymphoma is used for the staging of Hodgkin lymphoma and non-Hodgkin lymphoma. So we have limited stage lymphoma, bulky, and advanced stage lymphoma. And we have stage 1, stage 2, stage 3, and stage 4. Stage 1, we have isolated involvement of either one lymph node area, for example, spleen is considered a lymph node area, or one extranodal focus, for example, lung, liver, or marrow. In stage 2, we have confined to one side of the diaphragm with involvement of any of the following, either greater than 2 lymph node area or greater or equal to 1 lymph node area with limited extranodal spread. In bulky, we have feature of either stage 2 or stage 2E that include a large single nodal mass. For Hodgkin lymphoma, the cutoff is greater or equal to 10 cm or greater or equal to one-third of the chest width, and for follicular non-Hodgkin lymphoma, the cutoff is greater or equal to 6 cm. Advanced stage lymphomas involvement of either of the following lymph node on both sides of the diaphragm and supradiaphragmatic lymph node plus the spleen. So either of them is the advanced stage of the lymphoma. In stage 4, we have disseminated non-contiguous spread into extra lymphatic organ like liver, lung, and marrow. A and B are the modifier. A means the absence of the B symptom, while B is the presence of B symptom. So staging is based on the number of affected nodes, the presence or absence of the B symptom, and whether or not the disease is present on both sides of the diaphragm. Risk stratification, unfavorable prognostic factors for limited stage are the high ESR like greater than 50 mm without B symptom or greater or equal to 30 mm with B symptom. High LDH B symptom involvement of greater than 3 lymph node areas greater or equal to 1 extranodal site, bulky disease, age greater or equal to 50 years. Interpretation, we have favorable Hodgkin lymphoma without unfavorable prognostic factor, and we have unfavorable Hodgkin lymphoma with unfavorable prognostic risk. Then we have international prognosis score which is for advanced stage Hodgkin lymphoma risk factors. 1 point is given for each factor. Albuminemia less than 4 gram, hemoglobin less than 10.5, male, age greater or equal to 45, Lugano classification stage 4, WBC greater or equal to 15,000 per mm cube, and there is lymphopenia, lymphocytic count less than 8% or absolute lymphocyte count less than 600 per mm cube. So the scores are used to estimate the freedom from progression and overall 5-year survival rate. Treatment, so regime is selected on the basis of risk-based treatment is given. Limited stage favorable Hodgkin lymphoma, short course of chemotherapy with radiation. Advanced stage, so long course of chemo without radiation, so chemo is given. Due to high cure rate, the initial goal of treatment is remission rather than palliation for all stages of Hodgkin lymphoma. Chemo first-line treatment for all patients, typically ABVD, adriamycin, bleomycin, vinblastine, and dacarbazine. Alternative treatment in advanced stages are refractory, Stanford 5, doxorubicin, vinblastine, meclorethamine, vincristine, bleomycin, etoposide, and prednisone. Other is Biakov and other treatments. So we have autologous stem cell transplantation can be used for high-dose chemotherapy in patients with relapsed or refractory disease. Long-term management, so survival at risk of disease recurrence, especially in the first 5 years of the treatment, and long-term treatment-related complications. Counseling and screening are required to prevent and identify potential complications. Prognosis, so Hodgkin has a good prognosis with 5-year survival rate of 80 to 90%, and in children greater than 95%. Lymphocyte rich and nodular lymphocyte predominant have the best prognosis among all subtypes. Prognosis is largely determined by the disease stage. There is an increased risk for treatment-related second malignancy like breast, lung, and colorectal. So that's all about Hodgkin lymphoma.